Okay, so I'm going to get started. So today's talk is mainly, we are going to focus on the right heart echo. And the right heart is always almost, always considered to be a forgotten or overlooked half. So I always use the analogy in the cath lab. We are doing a lot of left heart cath, and we're doing coronaries. Mostly we focus on the left heart, but at the same time, we're doing a lot of right heart cath. And that's what we are interested in. We're doing a lot of hemodynamics. And surprisingly, with the advance of echocardiogram and a lot of things done in the cath lab can be also obtained just through the echo. So we're going to talk about the right heart echo, and we have a lot of numbers. We have a lot of formulas. So I'm going through those today. It's very basic. Okay, so that's fine. So this is the outline. My talk is going through the structure, obviously the RV size and the function of the RV, and also the inflow, outflow, the valves, tricuspid and pulmonic valve. And then finally, we're going to talk about the PA pressure and some related clinical relevant diseases. All right, so as we all know, the right ventricle, it's the most anterior structure of the heart. When we put a probe there, the most closest view is the RV, and it's in close proximity to the sternum bone. So right there, and it consists of three parts. The inlet, which has the tricuspid valve, chordae, papillary muscle, and the body has the trabeculated apex, and then the outflow. One of the typical, the specific structure the RV has is the moderate band, as we all know, that cross horizontally through the RV cavity. And also compared to the LV, the RV is relatively thin. It's usually using 0.5 centimeter. As we know, the LV thickness is usually less than 1 centimeter. So this, I remember yesterday, Steve talking about, how do we get the RV views? Typically we get the apical fold. We always do that kind of a standard. And this is the view. We are mainly focused on the LV rather than the RV, So often when we read the echo, this half is cut off. But anyways, that main focus is on the LV. But now we have these two more views. One is the RV modified view, and then the other is RV focused view. And as you see here, the modified view usually gives you the best view for the lateral free wall. And it also gives you the max longitudinal distance of the RV. So that's the RV modified view. And for the RV focused view, and this view gave you a larger minor dimension. So this should be wider than any other views. And also we typically use this view for RV longitudinal global longitudinal strain. So those are the views we need to keep in mind for RV echo. This is also, I remember Steve showed this as well, and how we cut off through, the ultrasound beam, cross through the LV into the RV. You need to really do the rotation of the probe so that you're going through the 3-line, 2-line, and 1-line. And the surprise you see, because the LV is relatively circular, therefore the size of the LV cross those among all these three views are very similar size, but it makes very different size for the RV because it's a very complex 3D for the RV structure. So you can see as when you cross as the 3 lines, it's the smallest and getting bigger and bigger. And this is the so-called RV focused view, give you the larger minor dimension. So this is the one. It's very important to acquire this view. So some very basic, especially for the first years, we're talking about the numbers here. So this is the first personal lung axis view. You can see the first view of all the echo studies, and you can look at the RV. So what is this size in your mind? So normally it should be close to 3 centimeter, and that is the number you need to remember. And that last one was the proximal RVOT, and then we give this short axis view. It's also proximal RVOT, and this size is slightly bigger. It's about 35, and that's the size. And then we go further distal, and you can see here is the distal RVOT, and we don't see very well with the pulmonic valve. Basically, is the insert of the base of the pulmonic valve, and you draw that line. That is the size of the distal one. Is supposed to be around 27 or below. So those are the 3 different sites we're measuring the RV outflow. And this is the apical 4-chamber view, and give you the dimension 1, 2, and 3, which is a longitudinal. And the size is 41, that's the base, and the mid segment, the 35, and the longitude is 86. So that is the linear numbers. And then we also talk about the 2D numbers at the end of diastole. And if you draw the 2D, and the size should be around 20 square centimeter for women and 24 square centimeter for men. So that is for the RV size. And this is also subcostal view, and then you look at the RV wall thickness. I believe this is the best view. When you have any question asking, for example, does the patient has amyloidosis, let's say, is there any thickness when we see a very thick LV wall and you want to pay attention, is this patient has also RV and hypertrophy? And this is the best view to look at the thickness of RV wall. And as we talked earlier, the upper normal is 5 millimeter. Now we switch to the RA. The RA size, again, we look at ventricular end of systole, and when the atrium is in diastole. So that is the minor dimensions 44, and the major is 53, and the area is around 18. So usually we use the LA. I think we use around 20. So the RA is slightly smaller compared to the LA, and about 18. So I think that those are the numbers I think we should kind of remember. It will be handy when we do the report. Oh, sorry. So now, with all the structure sizes, and we talk about the RV function. So in the guideline, of course, they have a list of these parameters. Well, I'm going to talk one after another. But most importantly, in the clinical setting, we use the TAPC the most, I would say. And next thing is the S prime. This is S prime, the pulsed Doppler peak velocity at the annulus. So these two, we really need to remember these numbers. And the TAPC is less than 1.6 centimeter. And I think this is RV guideline by ASCE in 2010. The chamber quantification guideline, I think that was 2015 or 2016. That gave us the TAPC is 1.7 as normal. So the slight difference. And the S prime, we're using the 10, and precisely probably 9.5, but make it easier to remember. It's just 10 as the normal. I'm also going to talk about a little bit of this myocardial the performance index later on, and the fractional area change. So this is a fractional area change. It's very similar to what we do for the LV. Of course, the LV is more sophisticated, give us the real EF, but this is only 2D. And the same formula using end of diastole, end of systole, the size. And importantly is, well, the number is 35% as normal. And importantly, that the FAC correlated to the ejection fraction very well based on the cardiac MRI studies. And also is this fractional area change is considered to be an independent predictive value for the RV function in clinical setting for mortality, for long-term outcome in many studies. So I think this is, although we don't use a lot in the clinical report, but we need to know this number. And then the TAPSE, and a lot of people don't like it. In ASC, you would call the TAPSE, CRAPSE, this is, but again, the beauty of this is simple and very reproducible and easy to acquire. So regardless of the image quality, and we pretty much, so that's why it's so useful. And again, you would put your sampling volume on the, actually you can on the base on the annulus exactly, or you want it close to the base of the lateral free wall. So put it there and then make sure this is parallel, because this is the beam angle dependent. So you want to make sure the motion of this RV contraction is, the parallel to this beam. So you will be able to acquire the maximum, the number. So you can see sometimes there's multiple lines here. You can see here. So you want to make sure, usually I go the lowest going towards the line, or from the top line, get up to the peak of this mountain. So that's, you measure it to the distance here. The normal is 1.7. The second most important number for the RV function is the S prime using tissue Doppler. And again, on the same side, you want to track the velocity, in contrast to the TAPSE, the unit is centimeter. That is the distance moved. But this S prime is the speed, is the velocity of the annulus excursion. So that the unit is centimeter per second. Okay, so the normal is as 10. And I remember yesterday, Steve talked about, asked a very nice question, what is this peak, which is the age of kick. Now, with advance of echocardiogram, and we use the string image more and more, start from the LV string to LA string and to RV string. So again, we need to use this RV focused view to do this analysis. The basically is the lateral free wall, and the longitudinal string is basically a longitudinal shortening as a percentage, and look at the change in length as a proportion to baseline length. And it's the same mechanism for the LV and the LA, and the number to remember is minus 20%. Now let's move towards the myocardial performance index. We don't use almost at all, but we need to know the mechanism behind. Actually pretty cool. It's called the myocardial performance index, or RV index of myocardial performance, or TAE index. There are all three different names, but the same thing. So the bottom line is look at the formula. That is tricuspid valve closure to opening minus the ejection time divided by ejection time. So that's actually interesting. You look at here. So I draw the line. If you see the EKG, this is the QRS, and you draw a line from tricuspid valve closure. So what happened to this cardiac cycle? Immediately is going to be an isovolemic contraction time. And then it comes to this side is when you put it on the pulmonic valve and the RVOT, you can see the ejection of that flow. So that is the real systolic ejection period of time. And then following that, before the tricuspid valve opening, and there's a isovolemic relaxation time. So basically is from TVC to TVO the entire time, and minus the middle chunk of the ejection time. So the result of it is basically isovolemic contraction and relaxation time. So important is the isovolemic contraction time basically is how much time you need to get yourself ready to go to work. And the isovolemic relaxation time is how much time you take to recover from the work. And the ejection time is the real time you are doing your job. So to think about efficiency, if someone is going to work with very little time, get yourself ready and go to work. And you can work for a long period of time and you're a good worker. So that comes to the MPI. If you work a long time for the ET, but with very little time to get yourself ready or to recover, then the number is smaller is better. So that's what comes to the performance index. The smaller is better, and the number normal in this pulse wave Doppler based on these two valves is 0.4 as normal, less than 0.4. And there's another way to, this is the index based on that because of the heart rate dependent. So you can index to a reference of 75. The other way to look at this myocardial performance index is you can see we can use in the one view of the tissue Doppler. Basically is you can see the S time is the time, the ejection time. And then you can see this is the isovolemic contraction and isovolemic relaxation. So you basically, this segment plus this segment divided by this ET, and that's what you get. And then the numbers will be slightly different in this tissue Doppler view, and this is less than 0.55 in contrast to 0.4 in that pulse, pulse wave Doppler view. So this is basically is the performance of RV function. Now, the other thing, it's very similar to LV contractility we used for the mitral valve regurgitation and to measure DP, DT. You guys probably also remember we used that in the heart failure with a reduced ejection fraction and to want to know how much reduction of the contractility of the LV. In that case, we'll pick up the mitral valve regurgitation and using that to the jet to measure. The formula is very similar, dPdt, and the slightly difference is the definition because the RV flow usually is not much, it's very short. So it's often go up to 2 meter, 3 meter, it's pretty big. And for the mitral valve regurgitation, it can easily go up to 4 meter, even 5, 6. So therefore, the definition of LV contractility dPdt, you are using the time or the velocity from 1 meter to 3 meter. In contrast, in the RV contractility, we're using this formula between the 1 meter and the 2 meter velocity. So you guys all remember the Bernoulli formula that the 4V square. And this is how this comes to the dPdt in the RV setting, you use 12 divided by the time between 1 meter and 2 meter. So that is this, but you need to know how this formula is coming from. The 12 is basically is 2 square is 4. Basically you're using the 2 square, and this is 16. 4 by 4 is 16, and this 1 by 4 is 4. So 16 minus 4 is 12. That's how it comes from. And when for the mitral valve regurgitation for LV, the number is 32 because you're using 3. It is 36 minus 4 is 32. And obviously, the contractility, the dBdt number is smaller, and for the RV is 400, and for LV is usually 1,000. All right, so we're done with the RV RA size and function. So we're going to talk about a little bit for the valve. So start with the tricuspid valve, and these are the basic views. You need to kind of remember which leaflet of tricuspid valve. And the only view you can see the posterior leaflet is this inflow view. And this you can see the posterior leaflet only through this view. And then obviously this is the anterior leaflet. And if you look at the short axis view, and this is the septal because obviously it's close to the aorta. And here's the anterior. Okay, and then we go to the apical 4 chamber view, and obviously this is the septum, and this is septal leaflets, and this is anterior leaflets. So there are different views, and you would know which leaflets, the anterior, the septum. Now we talk about a couple of disease and tricuspid stenosis, which is not very common and listed as rheumatic disease, tricuspid atresia is congenital disease, and a tumor obstruction or carcinoid. These considered to be our main reasons. Actually, most commonly nowadays is the after surgery with prosthesis degeneration. That's considered to be the most common reason for tricuspid stenosis clinically. Now, the other disease, it's kind of unique in this talk, especially for the RV, is the carcinoid. And as we know, carcinoid arise from GI tract is the neuroendocrine tumor that generates or produce a number of vasoactive substance, including bradykinin, histamine, prostaglandin, all these. So that is causing, flashing, diarrhea, asthma, those typical syndrome. So the reason for this is only affect onto the right heart. The reason is all these vasoactive substance, it's going to affect to the endocardium. It's because it's produced from the liver, going through the IVC into the RARV. So it affects all the right heart endocardium and the valve, causing the thickness. But these substances will be degraded when it's going through the pulmonary circulation. What we talk about is because of the substances are degraded in the pulmonary circulation, therefore it's never get into the left side heart and would not affect the mitral valve or anything. So this is unique for the RV. How do we grade tricuspid stenosis? And it's very, very similar the way we all borrow from the left because that is very well developed. So we use CW, we use pressure half time, but the numbers are different because the right side is much lower in terms of the pressure. So when we use 5, 10 in the mitral valve, and we use 2 and 5, so anything above 5 is considered to be severe. And also the pressure half time, instead of using 220, and we use 190 as the formula to calculate the valvular area, 190 divided by pressure half time. So obviously this pressure half time is not very reliable, in the surgical patient, in someone who has pulmonary regurgitation or severe tricuspid regurgitation. So that is very similar. I think are easily to learn and to remember because of the left side. So that's just one of the examples with stenosis of the tricuspid valve. You can see such a ballooned up the RA. That's reminiscent of the LA in the setting of MS. Now we are talking a little bit about the tricuspid regurgitation, and we need to know the definition of a primary tricuspid regurgitation, which is mostly involving the intrinsic abnormalities of the tricuspid valve, and this actually accounts for 30% of overall tricuspid regurgitation, and the 70% is due to secondary, or we call the functional TR, mainly due to the annular dilatation. So that's the reason here, and the tricuspid regurgitation is due to the functional TR is due to the tricuspid annular dilatation, and this is also secondary to the RA dilatation and RV dilatation. That could be in any clinical setting, for example, the atrial fibrillation or pulmonary hypertension, because of this volume overload or pressure overload causing this dilatation. Eventually, you basically stretched the annulus and causing this functional TR. And look at the structure. And when we talk about three leaflets, there's septal and anterior and posterior. And most of the time, the remodeling because of the annulus dilatation is, involves the anterior and the posterior leaflets most of the time. And the septal is minimally affected because it's pretty much fixed to that area. And this is a simple number, basically is when you measure the RV base dimension, usually use 41, 42 as the cutoff of the normal, the base size. And this is very similar to that. Just one view for Epstein anomaly, the genital disease. Just remember this always in the board is the number of, one of the things when you talk about the difference between LV and RV is the tricuspid valves are always little displaced towards the apex. So the degree of this septal leaflets apical displacement is greater than 8 millimeter per square meter. Okay, so that's important. You index to the BSA, and the number is 8. To be qualified, you call the Epstein anomaly. And what we do see in clinically, pacemaker is more and more common, and this can cause an iatrogenic TR. In this case, you can see this, stuck there and causing, obviously this is going to leak from here, and adhesion of the leaflets to the lead, and sometimes to the cordes, and this is causing perforation. So all these and can causing, this is more secondary, and you can see the dilatation of that. It's the annular stretch, and leave the coaptation is not very well. So these are all the reasons. That's why we see pacemaker related the TR jet. Now, this is often things we kind of need to remember in the echo when we read, often in the aortic stenosis, right? So in aortic stenosis, when you see this, which is a good sign, which is not very bad. And if you see the rounded, this is because the valve is so small, it takes a long time to equilibrate the pressure gradient. So the same mechanism you want to think about, but it's the opposite in this right side heart, is when the TR, you see this is rounded, and you know this is a small hole, and it's relatively mild regurgitation. But when you see such a sharp and very short acceleration time, and you know this is it's big opening, and the pressure is equilibrated very quickly. So that's what you look at, just the contour of the jet to know how bad is the valve area. It's applied to same for aortic and the aortic valve, the mitral valve, and also the tricuspid valve. So there are many different ways when we look at the tricuspid valve evaluation, the TR jet, you want to look at the vena, the VC, vena contracta, and the velocity, PISA, and also the hepatic vein Doppler, and all these we need to evaluate. And the severe criteria of severe TR is the jet areas, it's greater than 10 square centimeter, and the VC is 0.7. That's similar to the MR, severe MR. And this we already talked about, but I'm going to talk about a little bit of a hepatic vein. So that is the hepatic vein flow reversal. And so this is what the red color goes up during the systole, and you look at the EKG during the systole, and the flow goes up. Normally, it goes down, and also during diastole. So that's what we should see in a normal right heart, right atrial pressure. So this is during systole, ventricular systole, and actually is the atrial diastole, and that's the majority of the flow going out. And then during the ventricular diastole, the little smaller flow. And with the increase of RA pressure, and you can see the jet is more shifted toward the right, and this becomes tiny. And when it goes up above 15, and you can see the reverse flow. So that's what we look at the hepatic vein in this setting, for example. And what is the estimated RA pressure here, just based on this view? And you know this is the QRS, and this is the systole, and this is tiny. And the majority of flow happens during the diastole. So I would say this RA pressure is probably 5, 10, 10 to 15. So maybe I would pick up probably at least a 10. So that's what we look at the flow reversal. And IVC, we all know, we measure, and the new guideline is a little tricky. They can give you 3 and 8, used to be 5, 10, 15, 20. So now we use 3 and 8, you plus the TR jet for the PA systolic pressure number, and the distance of this measurement towards the opening, the osteo of the RA, is anywhere from 1 centimeter to 3 centimeter. So, if you take average, is 2 centimeter away from this. Now let's talk about the PA pressures. So there are many different ways and formulas we can use to measure the PA pressure. And so this is the typical way we are using is the tricuspid valve regurgitation. And using the Bernoulli square 4V square plus RA pressure. So that's the most common way we're using the TR jet here. And but often we don't get it. So in the report, how many times we see that the inadequate TR jet, unable to report this PA systolic pressure. And there's a way we can measure the diastolic pressure, and that we can use the pulmonary valve, and then during end of the diastole, again using the same formula, but what you get is the end diastole pressure. Now we can also get the mean PA pressure, and that's the same way we can do the VTI and give you the mean, the TR jet, and the pressure. In this case, instead of the peak velocity, and you get the mean gradient, and of course you get the mean PA pressure as well. The other way we use very common, probably secondary, most common is after the TR jet is the mean PA pressure. The pulmonary valve exertion time, sorry. And you kind of want to know this formula, 0.62 by acceleration time, as 90 minus of it. So that will give you the mean PA pressure. And you know the normal should be 25 below. That is the criteria we use for diagnosis of pulmonary hypertension. So this is how we get the mean PA pressure here. You put also put on here and the peak of the pulmonary regurgitation. If you put this velocity there, and you will get the you plus the peak one, you get 37 and plus 3, and you're going to get a 40. And if you're at the end of the diastole and you get this one, you're going to do the end of diastole, and the plus 3 again, 21 plus 3 is 24. So that is how you get the mean PA pressure and the diastolic PA pressure. So what's the difference between echo and the cath? And here is a case, the echo assessment of the PA pressure is in 69, right? It's a peak, and the mean is 40. And the same person going through the cath, right heart cath, in the room air, and the oxygen sets was only 87%. The pressure is 90 and 54. If you give 2 liters of oxygen and the sets go up to 93, and the pressure 66 and 38. So you can see when the sets drop during cath, obviously the pulmonary circulation constricted, and that causes the PA pressure goes up. So the cath, often you see the pressure is overestimated compared to the echo. So I'm going to quickly going through some of the calculation. Here is, we all know that the mean pressure, same as the mean blood pressure, is equal 1/3 of systolic blood pressure and 2/3 of diastolic blood pressure. And the same thing applies to the PA pressure. So here is this formula I think we all need to know is the vascular resistance equals the pressure divided by cardiac output. So in this case, if we give 45, 1/3, 15, plus 30, 2/3, 20, 35, minus the LAP is 12, divided by 4 is 3. So the wood units will be 3 in this case. And the other way we can use this formula to calculate pulmonary vascular resistance is using these 2 views. One is the tricuspid valve, the TR jet. The other one is RVOT, pulmonary valve, the TVI. So basically is the TR velocity divided by the VTI of the RVOT times 10. So basically it's 2.8 divided by 10 times 10. So it's roughly is 2.8. It's just a rough number. I think it's very handy when you think about if someone has really significant increase to pulmonary vascular resistance. So the normal PVR should be anywhere, between 1 and 2. And for pulmonary hypertension, the definition is greater than 3 Wood units. All right, so nowadays we need to pay attention to exercise. So we all know that there's a disease entity we call exercise pulmonary hypertension, which means at the baseline, the patient has normal pulmonary PA pressure. But with exercise, there's a significant increase of the PA pressure. So during the exercise, we know here the PA pressure minus LA pressure equals PVR times cardiac output. So the PA pressure always slightly goes up. And we have physiological response in athletes. If cardiac output with exercise go up significantly, at the same time compensated by markedly reduced PVR, the resistance goes down. So the final result is the PA systolic pressure does not go up that much, maybe slightly up a few points. Excuse me. Now, in the disease condition, the PA pressure will go up a lot. They use the 43, the PASP, as cutoff during exercise, also using 30 for the mean PA pressure as a criteria. So now the so you can see the exercise pulmonary hypertension can be the result of two main mechanisms. One is based on the formula, the pulmonary vascular resistance goes up. So that is giving you the group 1 pulmonary hypertension. So in this case, because this goes up and the PA pressure goes up. And the second actually now is become more common is because of the left atrial pressure goes up with exercise. And that is typical from left heart failure. So now we have seen more and more, especially the diastolic dysfunction. When you make these people exercise, the LA pressure, the wedge pressure goes up. And therefore, the pressure transmitted into the capillary of pulmonary circulation and causing the PA pressure goes up. So in the end, this is basically is group 2 pulmonary hypertension. So that is very important to know how do you interpret it, how do you try to dissect the mechanism of pulmonary hypertension, group 1, group 2. So this, remember, you see, this formula is very important. Put all these factors into consideration. Finally, I'm going to talk about the pulmonary embolism. So this is often the case. You guys were called to, especially during the emergency, go to the ED, go to the ICU, to ask you, does the patient need, basically they want your guidance about the diagnosis. Is this massive PE or is this a submassive PE? So that they can make a decision clinically talking about, thrombolytic therapy or fibrinolytic therapy. Now, in the echo, there's during the acute PE, there are a few signs. You look at the McConnell sign. Yesterday, I remember Steve gave a very good picture of that, and you can see these space mid-segment relative preserved. It's actually hypokinesis, but the apex is preserved. And then there is a sign called the 60-60 sign. We don't use it very often, and their studies show that. So these two 60s, one is the PA pressure, or you would say the TR jet, the velocity, and based on the Bernoulli, the 4V square never goes up beyond the 60 millimeter mercury. Why? Because during the acute setting, the RV is not going to generate that much force quickly. So no matter how much obstruction of the PA by the thrombosis, the pressure is not going across the 60s, okay? So you don't expect a very, very high PA pressure acutely. On the other hand, the pulmonic valve acceleration time is less than 60 milliseconds. And we know that the lower, the higher. The lower the shorter of this acceleration time, the higher of the PA pressure based on the formula we remember early on is 90 minus 0.62 times this acceleration time. So this is another sign with very high specificity for acute PE, if you look into that. So McConnell sign, 6-6 sign, and then lastly, you truly look at the right heart thrombus. How many times people have seen beautiful pictures, having in transition of the thrombus cross the PFO stuck there. So these are all the signs of the pulmonary embolism. This is the one study, also pretty much the last slide is, I'm not trying to, discuss this patho study per se, but more kind of related to our topic today, the right heart echo. So this study actually was, as you see, published in 2014 in European Journal of Medicine. The reason of this study is they want to see the effect of fibrinolysis in these intermediate to high-risk pulmonary embolism patients. Basically, is submassive PE patients, and they're using this TPA, and the primary outcome they're looking at, they randomized almost 1,000 patients, half and a half, into two groups, placebo versus the TPA. And the primary outcome is the mortality and the hemodynamic decomposition. Guess what? The mortality has no difference, and the primary outcome is driven solely by the hemodynamic decomposition of this with this TPA treatment. Significantly reduce the hemodynamic decomposition in these submassive PE. So what does this related to our topic is the definition of this intermediate to high risk PE, also known as submassive PE. So the definition of that is no evidence of hemodynamic change, which means no hypotension. Number two is RV dysfunction. Number three is biochemical changes in elevated troponin or BNP. So those three put together, you call the submassive PE. And they rely on the echo. So here comes the echo. In this particular study, they use this echo criteria to enroll the patient, to call the patient. So you need to meet at least one of these four RV dysfunction markers. So that's what I want you to remember. These are the major numbers you want to know. Number one, first two are size related. So this is per sternal or short axis view that almost the first couple slides I showed that the RV size should be, 30 millimeter as cutoff, and it's greater than that is dilated. So that's one number you want to look at. And the second number, actually the CAT scan also reports, the radiology will report, is RV versus LV size. So we know roughly the RV should be only 2/3 of the LV size based on the standard apical 4-chamber view in echo. And if the end diastole dimension of RV to LV ratio greater than 0.9 in this apical 4-chamber view or subcostal 4-chamber view, that's considered to be RV dilated. So these are the two most common ones where you're going to use it. And in terms of the function in the RV free wall hypokinesis, so that could be visually, or you can also use the TAPC, S prime, or even more advanced with string imaging. So I don't think they have specific look at either one of them. And lastly is the PA pressure. So remember, PA pressure goes up, but not necessarily it's need to be super high because it's not going to generate that much force to have that high gradient. So basically, that's what I want you to, once you are called to, and then this is you look at the size, you look at the function, and you look at the hemodynamic, the PA pressure. So those are the things you are looking at, the RV dysfunction. Okay, I think that's it. Any questions?
Hey, Dr. Chen.
Yeah.
Thanks for the great talk as usual. I have a quick question.
Mm-hmm.
How do you handle the estimation of the RV systolic pressure in the setting of severe tricuspid regurgitation? How does that affect your assessment?
It's significantly affected, but we just use that as a reference. But we cannot rely solely on that, and that's the limitation of the echo. But when it comes to, as there's a very severe, and we still get the jet, we still report the TR velocity and the gradient, but the number is compromised. But we don't have a better way to give you a real the PA systolic pressure number. In this case, actually many cases in the echo.
Thank
Good
you.
question.
So basically, we kind of look at it, report it, but we take
Yes.
it with a grain of salt.
Yes, I still report it personally. Yes. Anything else?
Dr. Chen?
Thank you, Dr. Chen.
Yes.
And for patients, for example, with primary tricuspid regurgitations like infective endocarditis, patients, if they have significant TR, they have RV dysfunction, and we think he's a surgical candidate. So how do we measure the RV annulus? Is it the same in the apical four chamber? Just a single view, we look at the annulus, and more than 4.6, that's dilated. Basically, my question is, how do we measure the tricuspid annulus in what view? And I believe I saw a value of 4.6. Is that correct? Or?
Yes, I think there's some of the discrepancy in different guidelines. And as I said that nowadays, I know how much advanced in terms of 3D RV, but I have not seen the guideline yet. But as far as we know, the best, as I talked today, is, the Fox RV view, and that will bring out the greatest dimension of this RV, the annular size. So you're trying to do that.
Okay. Right. Thank you very much.
Sure.
As usual. Thanks so much.